We have a dedicated cardiac CT scanner at St. Paul's, the first in Canada, one of the first in the world. And the reason we have one is because for the last decade, we've been trying to drive forward with a shift in practice. A shift in practice that is more patient-centered, that yields more accurate diagnoses, informs more valuable prognostic information, and helps guide medical management in a way that improves the health outcomes for the patients that we all serve. So every day we have 30 patients that come in that have some form of chest pain syndrome. And I believe what they want to know is, do I or do I not have coronary artery disease? What does it mean to me if I do? And how are you going to help me? So if we look at how patients are managed in the United States, I'll go to Houston tomorrow, and right now the current algorithm for the workup and management of said patients involves this very complicated process that is in fact neither cost-effective nor particularly accurate. It's cumbersome and leads to a lot of confusion. So for the last decade at St. Paul's, we've really pushed forward with a cardiac CT first strategy, because cardiac CT actually allows you to see the coronary arteries and allows you to be confident as to whether or not the patient has or doesn't have the very disease they're concerned about. But of course, as I'm always reminded by my clinical colleagues like Dr. Laxman, that we don't take pictures for the sake of taking pictures. We take pictures to help inform prognosis and help guide management in a fashion that will hopefully improve clinical outcomes. So it's not enough to just simply diagnose or exclude the disease, but we need to help understand how to better treat the disease. So again, we've spent the last decade working with many others to understand how we can use CT to titrate or adjust medicine to help improve quality of life and length of life for the patients we serve. We've seen data in collaboration with some of our colleagues from Scotland that shows, and we're not going to spend a lot of time on this, but what we're going to see here is in red, if you use the traditional pathway I just showed you, the blue is the CT-guided pathway. And the CT-guided pathway allows for a 40% reduction in downstream heart attacks. My colleagues at St. Paul's, led by Dr. Ignashevsky for many years and others in the Heart Center, have really bought into this concept of personalized medicine, guiding medical therapy not on the basis of the risk of the disease, but whether or not the patient has the disease as defined by their CT. And this pathway has resulted in a significant improvement in clinical outcomes. But where I'll transition to is where we've been moving in for the last number of years, and that's to answer the final question that comes up when we're helping a patient who has suspected heart disease, coronary artery disease, and that is, should the patient have a stent or not? And the problem with CT is no matter how robust it is, no matter how accurate it is, no matter how it can guide medical management, it has never been able to answer this question. It's never been able to really tell us whether or not we should stent or put a metal cage within that vessel and open it up. In the last few years, though, working with a group from Stanford, we've really pioneered a technology here at St. Paul's that has helped us better understand how to answer that question. And that technology is something called FFRCT. What it does is it integrates fluid dynamics, in particular computational fluid dynamics, the very laws that govern, for example, wind speed and drag when they design a plane, or when they design a race car, they use fluid dynamics to determine the overall capacity of the car to drive at a certain speed. Well, for years we had this anatomical model and we couldn't do anything with it. But through the integration of computational fluid dynamics, we not only provide the anatomy, but we can actually provide something called physiology or pressure or flow. And it is that very pressure and flow that is needed to determine whether or not we should stent an artery. Historically, the only way to get that pressure is to put a wire in the coronary artery, potentially exposing the patient to risk and an invasive procedure. Instead, now we can make that diagnosis and we can confidently evaluate flow without actually doing an invasive procedure. So this is a case that we had in our hospital. You could see this patient has significant narrowing. You see everything in red is abnormal. That means abnormal flow. Simply by taking their anatomy and all of the equations that govern fluid, whether it's blood or any Newtonian fluid, as they say, can be calculated, and you can actually calculate pressure and resistance in the coronary arteries. In doing so, what we could see here is not only does this patient have a significant narrowing, but that narrowing is causing severe flow disturbance. It's causing significant pressure loss in their heart arteries, and this patient needs to be stented. What we're working on beyond that is some very interesting work. If you imagine that we can actually take anatomy now and extract physiology or extract flow by integrating the equations of computational fluid dynamics, the last question that our interventional colleagues have for us is, well, that's great that you can tell me that that's a significant lesion, but how do I know if I open that lesion up, if I stent that artery, that the flow will improve? That's a good question. Right now, there's no way of telling that. But what if we could actually take the vessel and model a stent so that we see here all those values, anything below 0.8 is abnormal. But what you could see is we can actually model the stent and actually open up that artery where there was previously a narrowing and virtually open it. Simply virtually open it and recalculate the fluid dynamics to determine whether that stent will have the intended effect that the interventionalist desires. If she puts in the stent, will it actually help the patient? Or is it simply putting in a metal object without any incremental benefit? So we're looking very carefully with a group from Belgium and a group from Korea to better understand whether we can use these non-invasive tools to determine how to best optimize the revascularization or the stenting strategy to help optimize clinical outcomes in a fashion that is cost-effective. No one wants a stent if it's not going to help. The system doesn't want it, the patient doesn't want it. And so to provide that information before the procedure is, I think, a wildly exciting opportunity. And here, this is just going to play, and I don't have a pointer, unfortunately, but what you could see here is in the vessel that's being mapped, you could see the pressure is going down, and you see the pressure drops quite a lot. It's 0.95, and it drops to 0.75. And there's a narrowing in the heart artery. When we open that heart artery up and virtually stent it, you could see that the pressure improves drastically from 0.78 to 0.91, suggesting that by opening that focal lesion that is causing flow disturbance, that lesion that is significant. We know that from our baseline imaging, but now we know that by opening that lesion up, the interventionalist can actually relieve the flow disturbance, improve the patient's symptoms, and potentially reduce that patient's risk of downstream heart attack. So the future for cardiac CT goes well beyond the coronary arteries. We have a number of collaborations with groups this is from the University of California, San Diego. And I've had the tremendous good fortune of working at St. Paul's, where we've really led the world of transcatheter valve intervention under the leadership and vision of John Webb. This has been a tremendous opportunity for me, and that opportunity has afforded us the collaborations and the broad reach that have enabled such advanced analytics, in this case taking a resting CT and again integrating computational fluid dynamics, not to look at flow in the coronary arteries, but to look at how the heart muscle is contracting and whether or not certain treatments will improve it. So I'll close there. I think the future for cardiac CT is really bright. I'm incredibly proud to work at St. Paul's. I'm incredibly proud to work with the team of cardiologists and colleagues at the Heart Center. Our cardiac CT team, with their support, is the most prolific in Canada and probably in the top 3 in the world. And that is, in no doubt, due to the tremendous support of the foundation, the institution, and my friends and colleagues, and certainly the opportunities that have been afforded to us by our patients. So thank you again for the privilege.